Hi friends, today we are going to discuss a case where we used a multi-gated transluminal pathway for the drainage of pseudocyst with 20% necrosis. If you see the CT scan and here is a pseudocyst, if you had a small communication here and spreading like this, but if you see the shape of this portion is very tense and round, and this portion is relatively not tense. So, though there is a small communication here, we feel it's a flip valve mechanism that fluid may go from here to here, but it cannot come back from here to here. So, single drainage of this portion may not lead to the drainage of this portion. So we decided to use this technique and put a multiple stent. If you see the stomach here, stomach is compressed between these two portion, and patient is symptomatic in form of vomiting and abdominal fullness and anorexia, but he does not have fever. So we did a EUS. This is a tense portion of the pseudocyst. It is around 10 centimeter. And this is a lax portion. This one is a lax portion of pseudocyst. And even in EUS, you can see the small communication here. So we first placed a 3 stent in first portion. And you can see the endoscopic image of this multiple plastic stent in the tense portion. And then we again inserted a EUS scope, select the site, and 3 another stent placed after needle puncture and tract dilatation in this portion also. So total 6 stent and 2 transluminal tract into the cyst has been produced. So this is first reported by, and if you see the post stenting image of stent, this is the end where the first cyst has been drained, and this is the second portion of the cyst that we have drained. And this is first reported by Dr. Shyama Varadaraja from USA. And that he says that the multiple transluminal gateway technique for the complex WOPN via EUS superior than conventional drainage. And this article is published in the Gastrointestinal Endoscopy in 2011. And surgical debridement in such a case, complex WOPN is around 55 and mortality is around 14%. While conventional drainage has a limited success and many persons may require surgery later on, MTGT is a novel EUS-based technique using multiple transluminal tract. In study design, it's a retrospective cohort study, total 60 patient. MTGT group is around 12 and conventional drainage group is around 48. Inclusion is any complex anatomically feasible WOPN more than 6 centimeter and divided into the conventional drainage versus MTGT. Now 2 or 3 sites has been created and multiple plastic stent has been placed. Apart from this, because it's a significant necrosis, they have placed a nasocystic catheter in site 1 for the continuous saline irrigation every 4 hourly. In our case, we have avoided it deliberately because necrosis is less than 20%. And optional pancreatic duct stenting if leak is found on ERCP, but we avoid this also. And if you see the clinical outcome, treatment success rate of MTGT versus CDT is 91% versus 52%. Surgery is 0% versus 17%. Endoscopic necrosectomy in 1 case versus 3 case, and death is 0 versus 3, and complication is 0 versus 5. However, though it looks like advantageous MTGT, there are 4 limitations. One is that a selective anatomy is very, very important. Such type of anatomy where you can create a multiple tract in loculated cyst or complex WOPN that has to be identified. And for that, your image knowledge has to be good and you have to discuss it with the radiologist. And where you are creating a tract, it should be very close to the lumen. It is a retrospective design. And second is sample size is very 12, because only 12 cases they have to do MTGT, otherwise 48 cases they have to do conventional drainage because of anatomy. Long-term stent outcome was unknown in 2011, but in present era, everybody knows that it's successful, and it is a safe, effective, and minimally invasive option in selected patient. So our patient is doing good and excellent with all the symptoms has been relieved and taking orally. Weight gain has also been noted. Please give your comment in the comment section, as your comments will help us to improve our techniques, as well as if there are any loopholes in our presentation, then we can improve it in the next case, and we can discuss it academically. So in future, more and more cases of like this can be treated minimally invasively. Thank you. I am Dr. Swamin Shah, Gujarat Hospital, Surat. Thank you.